At the Swiss International Prostate Center, our philosophy is a kind of Swissness. We focus on quality of care for the patient, on technology, on good hospital environment. The idea of this center is to provide multidisciplinary management of prostate cancer. So from diagnosis to treatment, we really try to find what's the best option for the patient.
Before undergoing robotic surgery, all the issues related to the procedure were clearly explained to me. In particular, I was aware that there was a chance I may have to face further treatment following the surgery, and all the issues related to continence and potency were also explained much in detail. I was operated on just over 2 months ago, and the recovery has been going really well, and it has matched what I was told to expect.
We performed the first laparoscopic prostatectomies in early '99, and then we moved to robotics early 2003. One of the benefits of robotic surgery is around impotency. Today, we really have dramatically improved the quality of surgery and dissection. We are a training center for robotics. We are the only center certified in Switzerland from the EAU, and that gives us the opportunity to bring young fellows to teach them all the procedure of robotic prostatectomy.
Fusion biopsy we use in case of suspicious cancer to detect significant cancer after an MRI examination. The focal therapy is the next step. We use focal therapy to treat cancer localized in the prostate. To get a good fusion and focal therapy, we need a radiologist because the MRI is very important. Detection, treatment, and control of the treatment in case of prostate cancer.
We have in our group studies. One is to correlate the results of the MRI pre-biopsies with the radical prostatectomy surgeries. Then we can see if our target before the biopsy corresponds to the reality of the prostatectomy. And the second is to correlate, to be concordant with the MRI and the histology with the biopsy, to be more and more accurate for the target of the MRI.
Today, the selection of the patients is better. We can, thanks to the MRI, have a better idea of the disease. Thanks to the fusion biopsies, we have a better idea of the location and the type of the tumor. We operate much less low-risk cancer patients. Probably it's decreased by 50%. With 100 patients, 75 will be operated and have the prostate removed, and 25 will have a focal therapy. And of course, some other will be eligible for radiotherapy.
I've benefited from active surveillance during a few years, regular checkups, ultrasound, MRI, biopsies, until evidence was found of an encapsulated malignant tumor in my prostate that led to a radical prostatectomy 3 months ago. I felt very comfortable with a beyond informed consent attitude, meaning that as a patient, I was fully integrated in the therapeutic process.
We have developed monthly board of genetics. Every 2 weeks, we have the tumor board, and every week we have the radiology board.
We have all kinds of specialty treating prostatic cancer: oncologist, radiotherapist, urologist, radiologist, pathologist. So the main advantage is the multidisciplinary approach in the diagnosis and the treatment of prostatic cancer.
There are some genes which have mutations which are known to be associated with some adverse outcome in prostatic carcinoma. For example, one of these genes is PTEN gene. So we do some testing for PTEN mutation and some other mutations. It will help the clinician to choose what kind of therapy he will do for this carcinoma.
Since more than 10 years, all our patients are entered in the database. We share this database with the Clinique Saint-Augustin in Bordeaux, and we have more than 2,300 patients in the database. And we can follow in real time some parameters we want to know, like location of the margins, percentage of the margin.
We take care of all patients coming from any place with complication due to surgery or treatment of the prostate. When we have identified the problem, we discuss it again in the same board that discussed the pathology before in order to offer the appropriate treatment. Concerning incontinence, the first step is what we call the thumb sling, which is infraureteral support, a tape that is inserted surgically and has absolutely no mechanical component. If the tape is not enough, then we think about implanting an artificial sphincter. Concerning potency, we also can offer surgical options. One is to insert 2 malleable implants in the penis. This will give the necessary rigidity to patients who still have some degree of erection. If there is absolutely no residual erection, then we have to think about inflatable implant, which is more complicated, has a few components, but will allow the patient to recover erection due with a little mechanical device, and this little pump will help the patient.
The future for us will be to increase our network and to bring more colleagues in this kind of philosophy of a multidisciplinary management of prostate cancer.